This is Dr. Jamie Kaufman, and this is Dr. Kaufman's Acid Reflux Hour. Today, it's 10 things you should know about acid reflux. 10 things you should know about acid reflux. And so I'm just going to list them, and then I'm going to come back and discuss each. 1. Respiratory reflux, also known as LPR, acid reflux into the ear, nose, throat, airways, lungs, is 10 times more common than GERD. So for all those people out there who have heartburn as their main symptom, that's esophageal reflux. For every one of those, there are 10 people who have respiratory reflux. You could have silent reflux without knowing it, number 2. Number 3, asthma is one of the most common misdiagnoses in America, and respiratory reflux is the most common cause of shortness of breath. 4, respiratory reflux, 100 million Americans have it, is a massive and unidentified public health crisis. 5, the stomach enzyme pepsin, not acid, is the primary cause of most reflux symptoms, and certainly of benign and malignant growths. 6, proton pump inhibitors, PPIs, like Nexium, Prilosec, omeprazole, and so on, are ineffective and dangerous. They cure 0% of people of their reflux. 7, the biggest reflux triggers are eating too late at night, snacking, overeating, alcohol, carbonated beverages, and fast food. 30% of the American diet is fast food, by the way. 8, 99% of the information on acid reflux on social media is bogus, wrong, ridiculous, and even harmful. So there's so much misinformation. I did this blog predominantly for you to try to, this science, okay, this real, honest to God, spent 40 years studying this science. And so that's what I'm presenting to you, not made up ideas. You'll like this one. 9, your gastroenterologist, or GI, knows very little about acid reflux in general and is clueless about how to diagnose and treat respiratory reflux. And then 10, a healthy diet and lifestyle are the only cures for acid reflux. Now, that's a hefty list. That's pretty much flies in the face of all, let's say, medical mainstream. It says that the GI is interested in putting scopes down people and getting money for that and for facilities, and then putting them on a PPI. That's the major way that they work. They don't know anything about respiratory reflux and don't want to. Anyway, let's go on. So, go back to number 1, respiratory reflux. I came up with the term LPR in 1987 because I didn't want to say GERD. And when you see GERD and when you think of reflux, you may think of an ad on television of an obese man wearing a wife beater t-shirt with obviously remnants of a big Philly steak sub, leaning back, clutching his chest and moaning. Okay, that's heartburn. That's esophageal disease. That's not postnasal drip, too much throat mucus, and all these other symptoms which I'll go through in a second. So the idea that, and by the way, I think the term GERD ought to be abandoned, and we ought to say people have either esophageal reflux or respiratory reflux or both. And the term GERD ought to go away because it's been a wastebasket for all reflux for so long. And I think it's important for the medical establishment to begin to recognize respiratory reflux since it affects so many millions of people. I mean, 100 million people. How's that possible? Well, take all the people with COPD. Almost all of them have reflux, especially if they don't smoke, it's reflux. Take all the people who have chronic bronchitis and cough. Take all the people who have asthma. Take all the people who have sinus problems. Take all the people who have pseudoallergy, thick mucus. And so it adds up. And you'll see that a huge number of patients are misdiagnosed. And neither you nor the doctor know that the underlying problem with your sinuses is actually reflux. And so multiple surgeries is not going to get the answer. Asthma specifically, I want to mention, is one of the most common misdiagnoses in America. I don't have data on it, but I've been in practice a long time, and on the form, the patient says they have asthma on the intake form. And I ask them, when you have an asthma attack, do you have trouble breathing in or out? And basically 4 out of 5 say in. So that's not asthma. Asthma is exclusively difficulty getting air out of the lungs, a swollen bronchi, and can't get the air out. Anything else, in, reflux. And it's actually, reflux, the most common cause of shortness of breath. I'm doing a study now, which I'm getting ready to analyze the data, but shortness of breath may be the third most common reflux symptom. And there are 3 types of shortness of breath in my book. The first is exercise or exertion. You go up 2 flights of stairs and you're huffing and puffing. Shouldn't be 2 flights of stairs, that's number 1. Trouble getting air in or out if you have true asthma, laryngospasm, or problems with reflux. Getting air in is reflux most of the time. There are other causes, but 90%, and it's certainly not asthma. The third type is, there's a word in medicine called pathognomonic, and I'm taking credit for this one. Pathognomonic means this symptom means that disease, period. There aren't other choices. The inability or discomfort taking a full breath in is pathognomonic for respiratory reflux. And all those people have normal chest x-rays and pretty normal pulmonary function tests. And so that we know that this is somehow vaguely mediated because the vagus runs everything, right? The vagus runs the respiratory system, the digestive system, and the cardiovascular system. So the types of shortness of breath, when I ask people who say they have shortness of breath during my interview, I describe the 3 types and I say, which do you have? And to my surprise, number 1 is inability or discomfort taking a full breath in. And people really describe that as shortness of breath. It is respiratory reflux. Let me say it again. Inability, discomfort taking a full breath in is respiratory reflux. You got it. I want to talk a little about pepsin, but it gets big. I spent 40 years studying pepsin. Pepsin is the enzyme of the stomach. Hydrochloric acid and pepsin come up when you reflux. It's a big molecule. It attaches to tissue. It gets embedded in tissue. If you look at my last blog on alkaline water, it's a man made out of water. If you look at that, you'll see a biopsy of a vocal cord that has terrible reflux and an ulcer. And all the brown stuff in there is pepsin. So pepsin causes inflammation and swelling. That's why your lower valve isn't working, inflammation. The more you reflux, the more inflamed it gets, the more you reflux. What a cycle. It's really the primary cause of most reflux symptoms. I was pausing because acid, for example, causes laryngospasm. And acid does cause others, but most of the things, the growths, the swellings, the hoarse voice, the swollen vocal cords, that's pretty much because there's pepsin. And by the way, that's why we recommend a low acid diet. Giving the pepsin acid makes acid activated pepsin. So that's the kick in this, is that the pepsin is actually activated by acid. That's the connection. So you want to wash it out. You want to get rid of it. I love to talk about proton pump inhibitors. They're ineffective. They cure 0% of people. They have a lot of side effects. I had a patient, I think I mentioned this before, young man with abdominal pain. I went to the hospital, was admitted, had $100,000 worth of tests, ended up seeing me. I said, what are you taking? He said, I don't know, 3 things, and one of them was Prilosec. I said, stop the Prilosec. Abdominal pain, people don't know, is a real symptom, a side effect of PPIs. Since 0% of people are cured by PPIs, They're a big Band-Aid. They work best for people who have heartburn, but even then it's only about 60% of people get benefit. So I have no way. I have no way of knowing at this point if there is any FDA investigation of the side effects of PPIs. The long-term PPIs increase your risk of cancer. So if you take them for a long time, your risk of esophageal cancer increases. And why would that be? It takes away the symptom of the heartburn, but the disease goes on unabated. So PPIs should go. We have better alternatives. Read my recent article on over-the-counter medications, and there are specific articles on famotidine, alginates, and so on. So, biggest reflux triggers. I wrote a thing in the New York Times several years ago, the dangers of late-night eating, and it was the #1 most emailed article in the New York Times for like a week, which is pretty unheard of. And so, if you go to bed with a full stomach, you're refluxing all night. It's silent reflux. And if you go to bed with alcohol and a buzz, it's reflux all night. So what happens is you have silent nocturnal respiratory reflux. SNOR, S-N-O-R-R. Silent nocturnal respiratory reflux is the disease of America today. And a lot of it has to do with our sort of cultural big event, the evening meal, alcohol's involved, entertaining, often later than it should be. So if you're going to bed, we used to say 3 hours. If you have reflux, you want to get it cured, it's going to be 5 hours or more for at least a month. Along with, and please read the article on reflux detox. So the diet has to change. I recommend medication, over-the-counter medication, no PPI. So that's a biggie. Overeating, if you fill the stomach too much, it's going to want, some of the stuff's going to want to come out. Carbonated beverages and fast food, I've written a lot about, and carbonated beverages are the #1 dietary trigger of pepsin going to work because it's so acidic. By law, it has to be under 4, but unfortunately, a lot of them are around pH 2.9 to 3 point something, so they're too acidic. When I say 99% of the information on acid reflux, that's my number 8 here, on social media is wrong and ridiculous and even harmful. I say that because one of the things that I do in these reflux hours is I present a topic, and after that I answer questions. And some of the questions are so ridiculous and so completely impossible, ridiculous, harmful, many of them, that it hurts me to think that people are saying this works for me and then propagating it like it was an actual medical treatment. So I've written this blog for you. I do believe I'm the world's expert on respiratory reflux. I've been studying it seriously since 1981. I'm an academic. I was looking through some of my publications yesterday. I have two big books of them. My CV you can find at the bottom of the About Me. But I've been all over the country, all over the world, lecturing on this since the 80s. And you wonder, well, why hasn't it stuck? And that's because people don't make money talking to patients about their diet and lifestyle. They want to do testing that they'll get money for. Things that get reimbursed are what doctors do. We don't have any system yet. If I could get inside medicine, I would put some structure in respiratory integrated medicine, and I'd end up with, college graduates with no special degree and 8 weeks of training, and hire them as, I would say, reflux and dietary and lifestyle consultants, and they would answer questions of patients, and they would train them afterwards with the things that I would tell, no eating too late, and so on. So there's a lot of ways to restructure. Endoscopy would need to be done. We don't need gastroenterologists for reflux. Transnasal esophagoscopy can be done. Let's say one PA in a group would do it on all the patients who need it. So there's a whole question of how do you get information to people in the future. And that's part of my concern now. I'm reaching out to Mehmet Oz and also Kennedy to see if we can't have some conversations about integrated area-adjusted medicine. Anyway, it's beyond the scope of this talk. If you find something that seems like it's off the wall, it is off the wall. Okay, don't do it. Okay, don't do a juice cleanse if you have reflux. It's the worst thing you could do. I think that it's difficult if there's only one source of information. I find myself in a very bizarre position because I'm 77 years old, and I think the work is really important. I don't know how to get it to more people. So I think, if you will, and I'm not as good as I used to be doing these. I'm not as concise. I forget words. I'm old. But use this. Get your friends who are chronic throat clearing, your friends who have terrible whiskey voice, your friends who are clearing the throat or coughing all the time, to know that they have respiratory reflux, and give them information about the blog. The blog was written for you. It's basically a book. It's fragmented, but almost everything is on it. So, gastroenterologists are knowing about reflux. So, I was at Wake Forest University when the three giants of GI were there. In fact, I borrowed their pH probes to test in my patients. They said, oh, there's no reflux up there. That's just Vegas. And they said, no, there's reflux up there. So we tested it, and there was. But anyway, all the opinion leaders in GI have been familiar with my work, and I think they're terrified, because if I'm right, we don't need GIs to be treating reflux. And we certainly don't, because they don't do a very good job. To make matters worse, since they are the go-to doctor for reflux, the pulmonologist and the otolaryngologist, the allergist, they don't have anyone to refer to. There is no test, by the way, today for respiratory reflux. If the GI wants to do a Bravo for respiratory reflux, in my opinion, don't waste your time. They have absolutely no idea how to diagnose or treat respiratory reflux. They don't recognize it. So if someone has chronic throat clearing, a sense of a lump in the throat, and hoarseness, any of the respiratory symptoms, and go to a GI, the chances of you getting a good outcome, in my opinion, are remote. So it's not in their training, and it's certainly not in the training of other specialists who deal with the airways. So that leaves us with a healthy diet. I'm not going to belabor it. If you have reflux, you can't do little things. Ooh, the famotidine didn't work. Ooh, the Gaviscon didn't work. Ooh, I went on your diet for a month and nothing happened. It's intense. It's about diet. It's about sleeping on an angle. It's about medication. It's about restricting the diet. It's about no alcohol. It's about nothing out of a bottle or can. So there has to be a month of intense, no reflux during that month. And during that month, things will heal. When I mean heal, I mean you wash out the pepsin, and the valve that was all stiff and swollen will be nice and pink and work as a valve again, both of them. So I'm not going to belabor it. Dropping Acid was the first book to link the words reflux, diet, and cure. And the first 45 pages reflect about 15 years of basic science work. So anyway, I recommend, and Dr. Kaufman's Acid Reflux Diet, I believe, is a companion. The two books go together. So now I'd like to go to I'm sorry if this sounded rambling a little more than usual. I had no sleep last night. So I want to just say, that, sadly, that if any of you are on this broadcast and you are not using my Facebook, you're making a huge mistake. Sign up, put your name in, you'll get a topic each week. Like, people love the over-the-counter one. Let's see, what did we put up today? We put another article, a good article on alkaline water up today. So understand that you have this resource, and I really wish you'd look at it if you have a question. Oh, I have a hiatal hernia, and I read on the internet that I need to have surgery. Go on type in hiatal hernia, in a little search box and see what happens. So I'm really saying many of the questions I've omitted because they're not right. I take Gaviscon. This is Kim. I take Gaviscon every night before bed. Can I continue to do this indefinitely? And the answer is yes. Is sucralfate beneficial or harmful? This is Gustavo. In treatment of respiratory reflux. It's absolutely useless. It's a waste of money. Never helped anybody. I would not recommend, in fact, I would not recommend pretty much anything in the GI. Another big problem with reflux is a lot of people have esophageal dysmotility. It means that the normal stripping waves, peristalsis going from top to bottom, getting food from your throat to your stomach, is not working. And people get food stuck and pills stuck and so on. And the gastroenterologists want to treat these people with what are called prokinetic agents. The problem is that the reflux has caused the dysmotility. Fix the reflux, and the dysmotility will come back. Furthermore, the medicines are dangerous. They're bad, and they're bad side effects. One of them was, cardiac sudden death. So I just think there are very few people who have primary dysmotility. They think the dysmotility is causing the reflux, the other way around. The reflux is causing dysmotility. In my practice, I've had two people. I do esophageal manometry. I measure esophageal function. I had two people with aperistalsis, meaning dead tube. Nothing happens. All right? Both come back to complete normal, flat normal after reflux treatment. So there's the exception that makes the rule. Next question. Oh, I can't believe it. I'm so sorry I missed this. Jill, Dr. Jill, I have respiratory reflux and esophageal motility, and I'm on metoclopramide. Is this necessary? No, but get your reflux fixed. Do a detox, okay? Get a bed that goes up and down. You can afford it. Depends on how old you are, especially if you're young and you're refluxing like a bandit. But this motility is usually almost a secondary reflux. And it's a very important question because so many people are getting these unnecessary tests. You don't need to do esophageal motility. If you've done a detox, if you've done your very best, ask your primary care physician for a barium swallow esophagram, upright, standing, and supine lying down, and it'll see if you have big cricopharyngeal bar, the upper valve's not working. If you have dysmotility, it'll be seen, and you'll look and down. If it's refluxing back and forth, you still have no functioning lower esophageal sphincter. So the next question is from Jason, and it's one of those questions I put in. I remember I said the internet's full of misinformation. So have you, respiratory reflux expert, heard about people taking HCl and pepsin to resolve the reflux? First of all, I don't think you can get pepsin. The only pepsin I know that you can get is pig pepsin. Whatever someone's calling pepsin, I don't know what it is. And taking acid, I just finished saying that acid activates pepsin. So these things that people are advocating, which are acidic, it's essentially, this is like fighting fire with fire. So that's what I have to say about that. This is Lisa. If you're no longer refluxing, does the pepsin that's trapped in the throat continue to cause mucus, postnasal drip, salty sour taste in mouth? And would you continue reflux? So she wants to deactivate the pepsin trapped in her throat. No, she's got reflux symptoms. She's still refluxing in her throat. So you have to look at your diet. You have to look at your time of eating. You have to look at all of the factors. I've written about all of them. You have to look about exercise. If you have big-time reflux, you should not be doing exercises that push on the stomach, planks, sit-ups, downward-facing dog, heavy bench presses during the time you're trying to recover. And you should think of it as a time to recover. And it's going to require, not just one hand. It's going to require both hands and both feet and all of you to beat your reflux, and it will take you at least 4 weeks. of intense work. So unfortunately, the pepsin is still there, and the reflux is still there. It was a very interesting question. I don't really have a cough or sore throat or heartburn, but I have a salty, burning tongue, and sometimes my teeth feel sensitive. I do have postnasal drip. I've been on dropping acid for years. When I was a resident, there was a joke. The patient you least wanted to see come in the office was an elderly woman with burning tongue. And burning can be related, and burning throat. Now let's talk about burning throat first. If you have burning throat after a reflux episode, it was equivalent of heartburn, it happens periodically, usually after meals or in the evening, that's not neurogenic or nerve caused. If you have burning throat all the time, then that has to do with the vagus nerve. I've written a 3-part article on the vagus nerve, and I've written an article on how I treat neurogenic conditions. So I have experience with burning tongue. I don't know whether you have reflux or not. There's no way I can examine you. But I would look at the article first on a dry cough and then on the treatment. All you have to do is type in neurogenic. Now, all of you have reflux, okay? 98% of you don't have neurogenic problems, okay? So don't go running, I need to have amitriptyline and gabapentin for my reflux. You don't. But this person with burning tongue, it's neurogenic, chances are. And if it gets worse in the morning, then it's maybe reflux is making it worse, or it's just reflux. No way to know. This is a question that's difficult to answer. If you're no longer refluxing, does the pepsin that's trapped in the throat cause mucus? So the most common symptom of respiratory reflux is mucus. It's thick mucus. So allergy never produces mucus that gets on your vocal cords. You have to get off of there. It's thick. It's dry. Stay hydrated as well as you can. I have a bunch of these every day. This is 24 ounces. But if you still have mucus, I would not think you don't have any reflux. Now, pepsin, most places, for most people of reflux, doesn't cause any mischief. I mean, if you have big granulomas in your vocal cords, you got esophageal strictures, you got starting to have real nasal and sinus problems. That's another matter. But if you have mucus, the lining of the respiratory system are mucous membranes. When irritated, they produce mucus, and it's thick mucus, allergy thin mucus, reflux thick mucus. Another salty burning tongue. Sorry. How do you prepare alkaline water nasal spray? Just plain alkaline water? Yes. You take alkaline water. Okay, so let me explain it. Let's just say you're a singer on Broadway because you're doing 8 shows a week. And you have a little reflux and your voice is off a little bit, your vocal cords are swollen. When you swallow alkaline water, none of it ever gets on your vocal cords. Your throat clamps tight as your fist so you don't aspirate, so water doesn't go in your lung. But if you take alkaline water, this is pH 10. If you go on the site, you can order these, the last alkaline water article. pH 10. Pepsin dies at pH 8. This is the only thing you can do to help wash out pepsin more quickly than stopping your reflux. Do it in the morning, do it after meals, do it whenever you want. But if you have throat issues and voice issues, it's a real addition, spraying. Hey, I have a question. What is another way? This is a doozy. I am in such conflict with gastroenterologists. Basically, if we had a jousting war, one of us would die. I have a question. This is Alvia. What is another way to treat H. pylori other than heavy dose antibiotics, flagyl? Okay, So 100 years ago, H. pylori was everywhere, and people had ulcers. I haven't seen a duodenal ulcer since 1970 something. People who have H. pylori, the data are not such. My experience has been that in my opinion, is that asymptomatic H. pylori should not be treated. And if you want to know the truth, when people come to me with acid reflux, and I ask them, take the history, I say, when did your reflux begin? And they, believe it or not, tell me, after I was treated for H. pylori. So treating H. pylori will make you, and this data actually in the medical literature, make your reflux worse. So I'm not a fan of treating asymptomatic H. pylori. In fact, I should stop looking for it. Unless you have symptoms, leave it alone. Last one. I also, this is Jacqueline, has reflux, has a sinus pain, ear and jaw ache on my left side. So the answer is reflux can go up in the nasopharynx, a little puddle place. Read the article on the ear and the sinus, in the blog. And it can cause eustachian tube problems, popping, pressure, hearing loss, and tinnitus, and ear pain. But once we get to the jaw, I have no idea whether this is related to reflux or not, any of it. So I'm sorry that I don't have an answer for you. Jacqueline, your hiatal hernia is of no clinical relevance unless it's bigger than 6 centimeters, in my opinion. So anyway, there's been a lot of material today, a lot of opinions. It's interesting. All of these years I've been talking about the failure. The gastroenterologists have prevented progress in the field of reflux for 50 years. They've been sticking scopes down people and putting them on, and that's been the model for reflux basically since 1975. And so there's been little progress in the field. And they're doing things that they shouldn't. They're blading things and doing all kinds of crazy things to make money. So anyway, that's the story for this week. And next week I'm probably going to talk a little more about foods. Anyway, signing off.